Funding for this program made possible by the Investor Protection Trust, the State of Alaska Division of Banking and Securities, and AARP Alaska. In today's program, we'll examine 10 essential services of public health, and we'll also discuss what appears to be an increase in use of a highly dangerous illegal drug here in Alaska. Now here's your host, Ann Secrest.
Hello everyone, and welcome to AARP Alaska. Today we're delighted to welcome our guest, Dr. Jay Butler, Chief Medical Officer with the State of Alaska Health and Social Services, as well as the Director of the Division of Public Health. Welcome to the program. We're delighted that you're here.
Thank you, Ann. It's a pleasure to be here.
Please tell us a little bit about your professional background and how you wound up in your current position.
Well, I trained as a physician. I'm not originally from Alaska. I had neither aspirations to be in public health nor Alaska, but things sometimes work out that way. At a number of points in my training, both in medical school and during residency, I had some mentors mention to me that I might be interested in something called the Epidemic Intelligence Service, the EIS program at the CDC in Atlanta, which is an opportunity for clinically oriented people to have some applied experience in public health epidemiology. I did that, actually found that I really enjoyed that work, and ultimately came to what I thought would be my dream job for the rest of my life. I was board certified as an infectious diseases physician. I was seeing patients at Emory University 4 months out of the year, and the rest of the year working at the CDC in public health. About 20 years ago, a call came, one of those calls from the boss's boss, saying, you know, we have a position in Alaska that we'd like you to consider for a couple of years. Talked with my wife. We had 5 kids at home at the time, so it was a pretty big move. But we visited Anchorage in February and thought this actually looks like a great place to live. So we moved from Atlanta to Anchorage and very quickly found that Alaska was home for us. So I have 4 of my 5 kids have stayed in Alaska. I have grandchildren here, and it's home for us. My position with the state as Chief Medical Officer is one that I came into in 2007, originally when the position was first created. I was a state epidemiologist at that time, having gone from the CDC into the State Department of Health and Social Services, and was in that role for a few years, and then was with the Alaska Native Tribal Health Consortium for almost 5 years, and with the most recent change of administration was asked if I would like to come back into state service again. So here I am.
And here you are. Since this program is on the state of public health in Alaska, the first obvious question is, what is health and how do we measure it?
That's a great question, and I oftentimes point to the preamble to the Constitution of the World Health Organization, which defines health much more broadly than what we oftentimes think of. It defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease. So it's a real paradigm shift of how we think of health care. And much of the health care that we do in this country and in this state is really disease care. So it's a much broader approach and really a public health approach that looks at not just treating disease or even preventing disease, but how do we become whole and functional people.
So actually this may be linked. You have spoken on the topic of health, whether it's personal, public, or social. And is that one and the same? Is it, the answer is, it's all of the above.
It is all of the above. And I'm trying to incorporate ideas in terms of personal, in terms of both personal health care and personal behavior, which is an important contributor to the status of health, but also the public aspects, the ways that we as a people and the population level health management that occurs, and then also social in terms of what do we value. Some people have even defined public health as what we as a society no longer consider acceptable based on emergent scientific data. A good example might be of that last one might be how we view tobacco nowadays. If we were doing this, if you were Edward R. Murrow and you were sitting across from me 70 years ago, you would be smoking a cigarette, and I as a physician would probably be smoking a cigarette too. So a lot has changed. Very few people have ashtrays in their office. If we go back only 25 years, it was probably okay to say, do you mind if I smoke? The assumption is now, yeah, people do mind if you smoke if you're indoors. And so the social norm now is if you smoke, take it outside.
How we measure health, morbidity and life expectancy, has that changed over the years? Have those benchmarks changed over the decades? When you talk about the change, say, of smoking, but have those benchmark changes? Are there other benchmarks as far as measures of health?
Well, I think those benchmarks and those measures have been refined. Historically, we've looked at the life expectancy and the various causes of death as ways to measure the degree of health in a population. In some ways, death is easy because there's not a lot of debate about over who's alive and who's dead. It's an easy categorization. Right. I think it was William Farr was one of the fathers of public health, said death is fact, all else is inference. But that's a very crude measure too. Merely the number of years that a person has spontaneous respirations and a pulse is really not a good measure of health. So those statistics have been refined into looking at issues such as quality adjusted years of life, or if we're talking about causes of death, how they contribute not just to a cause of death, but also to years of potential life lost. The bad news is we are all going to end this earthly life at some point. The bottom line is life itself is a sexually transmitted condition that is 100% fatal. So we all do die, but how do we live our lives between birth and death is an important determinant of health, and the quality of those years is an important measurement of health.
You had mentioned in a presentation, you had mentioned the work done by Dr. Michael McGinnis. And what I found interesting is, and this is attributed to the Institute of Medicine, if we can go to this slide, the 10 essential services of public health. And I just want to go through this. Are these 10 essential services something that are used universally throughout the world or in the United States? And they include things from develop and enforce health and safety protections, link people to needed medical care, mobilize community partnerships for health, fostering health, enhancing public policies, ensure a competent health workforce, evaluate the quality and effectiveness of services, research for new insights and innovations, monitor health status. Number 9, diagnose and investigate health problems. And 10, inform and educate about health issues. Is this something that is universally accepted, or is that something that the U.S. has adopted?
Well, it's certainly seen as a standard the world over. In the United States, it's been adopted, though, as really a benchmark for all agencies to strive towards, whether they be state, local, or tribal organizations. In fact, there is now a public health accreditation board for these agencies. And that accreditation is based on 12 domains, which include the 10 essential functions of public health, as well as having the infrastructure to be able to manage and administer programs, as well as the ability to interrelate with your governing authority. which for us at the state level in Alaska is the executive branch, with some influence also from the legislative branch, since that's where our funding comes from. I think it's important to realize that if you've seen one state public health agency, you've only seen one state public health agency, because they are very different among the states. Some states actually have health boards that are completely separate from the executive branch or the legislative branch to which public health reports. Other states, it's in the flow of the executive branch, sometimes in a freestanding Department of Health where there is a Secretary or Commissioner of Health. Other states, like Alaska, have what we term a super agency, where public health is part of many other social service functions. So health is a little different because we really serve all Alaskans, whereas many of the social service agencies specifically address the needs of certain populations.
How does Alaska reconcile, and you in your position, how do you reconcile the fact that Alaska is a chronically underserved area? We always have areas where we need people. We need behavioral specialists. We need, what was the pharmacist? What was the other position that we always need?
Well, there's not many healthcare positions where we don't need more people. So, but I think the ones that really stand out to me, in addition to physicians, are nurses. And behavioral health specialists. Pharmacists certainly are very much needed also. In the tribal health system, fortunately, there's been the opportunity to use the public health service as a way to staff some of those positions.
But throughout the state, can you say, are all our areas throughout the state, are we meeting the needs of the public?
No, and it's important to realize that it is a very high calling in that we have 20% of the land mass of the United States here in Alaska. We have 0.2% of the population. Fortunately, it's easier on the road system where the population is fairly well concentrated. But as we get out to more rural areas, it's more difficult to provide those services. We are, I think, very fortunate that we have a robust tribal health system that has taken on some of those services previously provided by the Indian Health Service, and under tribal governance have continued and expanded those services. And it's been a really good partnership for the state also to work with those tribal organizations. We don't have city and county health departments the way many other states do, apart from the municipality of Anchorage, and there is public health authority in the North Slope Borough also. But in general, our state public health division is the public health provider throughout the state. And we actually also grant some of the areas that have the public health authority to provide public health nursing services, such as in Anchorage and the North Slope.
Optimistically answered. Very good. We'll be back with our guest, Dr. Jay Butler, right after this.
Health Essentials brings together AARP's health experts and columnists to keep you up to date on the latest food and nutrition trends, Medicare, and how to keep your mind and body strong. Visit aarp.org/health/health-essentials.
We're back with Dr. Jay Butler, Alaska's Chief Medical Officer. Like many other states, Alaska has its share of challenges. There's alcohol dependency, use of tobacco and drugs, cancer, heart disease, obesity, access to clean water and sewer services. What do you think are the top problems that Alaska faces?
Well, I'm going to focus on three in response to that question. The first group of challenges is substance use and addiction. We have historically had challenges with alcohol abuse, whether that be binge drinking or actual addiction, alcoholism. And we've also seen, like the other parts of the country, a huge increase in the number of overdose deaths due to opioids, including not just prescription opioids, but increasingly heroin and fentanyl. The second area of concern is unintentional injury. So that's accidents, well, I should actually say injury, period. So unintentional injury as well as intentional injury. So suicides, interpersonal violence. These are some of our leading causes of years of potential life lost. So they're not just leading causes of death, but also leading causes of premature death, disproportionately impacting our younger people. And the third area for concern is one that is always there, and that's new and emerging infectious diseases, whether it's things like Zika virus, which actually is not a new virus, but has recently spread into the Americas, and we're certainly concerned that it's going to spread into parts of the lower 48 in the coming summertime, or emergence of antimicrobial resistant organisms. So infections that used to be easy to treat may be becoming more difficult. If you want to know what wakes me up at 3 in the morning in a cold sweat, I think there's two things that I really worry about the most. One is a situation that actually has already occurred elsewhere in the United States. In Scott County, Indiana, there's been about 190 new cases of HIV infection during the past year. This is a small county. The county seat is about the size of Dutch Harbor. 190 cases of HIV infection. Almost all of these are associated with self-injection drug use, using mostly prescription opioids, pills that have been crushed up and then injected. Some due to heroin, but primarily prescription opioids. The other situation I worry about very much is emergence of drug resistance gonorrhea. We have high rates of sexually transmitted infections in Alaska, mostly chlamydia that we see, but we've also had higher rates of gonorrhea. And right now, those infections are still treatable, but not nearly as easily as they were only 10, 20 years ago. It's one of those areas where it feels like we're not making progress because these infections are increasingly difficult to treat. And if we get into a situation where we have a common infection like gonorrhea that is not treatable with antibiotics, we're basically back to the very early 20th century again.
Let's talk about the profiles. Let's talk about those who are affected here in Alaska. The drug use, the heroin usage. Who's using it?
Well, let's start. I think the easy answer to the question of profiles is there is no profile. The use of opioids has really spread throughout society and throughout all parts of Alaska. And it's, in part, it's easy to point fingers, it's easy to wring our hands, but I think it's an issue that we all have to look at without placing blame on anybody or minimizing that as much as possible, while we sort through how did we get to where we're at and now what do we do?
Right.
The rates of prescription of opioid pain relievers have increased fourfold from 1996 to around 2010. Over that same period, not surprisingly, the rates of overdose deaths have also increased roughly fourfold. In the years since then, we have seen a continual increase in overdose deaths. We've become more aware of the risks with prescription opioids, but the fact is we have a large population that has an opioid hunger. The opioids are very addictive substances. And why are we prescribing so many opioids? Is it because pain is so much more common? Probably not. But we also know we used to undertreat pain. There was a real hesitancy to provide opioids for treatment. And during the 90s, there was a shift towards how we viewed pain, but I think the pendulum swung too far. And it became increasingly common that opioids were the first drug of choice for treating pain. The quantities of the pills that were distributed just in case you need them, and I think we've probably all been told that by a provider at some point in the past 20 years, has increased quite a bit. So we've had a flood of opioids in our communities. And so they became very easy to obtain. The one particular slow release opioid had some challenges because for some people it didn't provide the pain relief as advertised, so they wanted more, and of course the prescribing instructions were to give it twice a day, but they were beginning to have pain, maybe even beginning to have withdrawals before their next dose was due. The manufacturer's instructions, well, you just need to increase the dose. Well, that really did increase the risk of overdose.
Right.
Also, actually the package insert gave pretty good instructions if you wanted to abuse the product. It described not crushing the pills because that would release a large amount of the drug. So whether you did it by mouth or injected the pills, that was a way to get big doses of the medication. And of course, one of the challenges with opioids, particularly when they're used for pain, is tolerance develops. So if they're used for long periods, oftentimes a higher dose is needed. Not for everybody, but for many people. And the opioids also depress the drive to breathe. And that tolerance develops much more slowly. So when the dose increases, and particularly if there's a sudden increase in dose, that increases the risk of overdose death by depressing the respiratory center such that a person will fall asleep and may actually stop breathing. And if they're not treated, they can die.
I noticed this report from 2015, Alaska heroin use is skyrocketing, and there were 4 times the number of overdose deaths in 2013 compared to 2008. But this report was from 2016, and what they're concerned about is fentanyl. Experts say the prescription drug can be up to 50 times more potent than heroin and 100 times more potent than morphine. So I assume that's on your radar right now.
Absolutely. And fentanyl's not a new drug either, but I think what has changed is fentanyl has actually been used as an additive in heroin. Back in the old days of heroin, when it was primarily a drug in East Coast inner cities, the drug was oftentimes extended and cut with inert substances, talcum powder, various things that we used to see medical complications of what was in the heroin. As the quality and concentration of heroin is increased, also the practices of what is added to it have changed. And sometimes fentanyl is used as an additive to heroin. And because it is so powerful, it creates an increased risk of overdose death. We actually do, in the medical examiner's office, test for presence of fentanyl in overdose cases. We have seen some in Alaska, not as many as in the lower 48, but other measures, such as heroin that has been seized in Alaska, there is indication that fentanyl is showing up in Alaska as well.
Just very briefly, you mentioned Zika, which of course catches everyone's attention. Should we be worried?
Well, we're very fortunate in Alaska in that we don't have the Anopheles species of mosquitoes that carry Zika. But we also oftentimes travel to the lower 48, and actually we oftentimes travel to Central and South America and the Caribbean and places where Zika is being transmitted currently. So the advice to travelers is to be very careful about mosquitoes, use your insect repellent, which of course we are used to more because of nuisance mosquitoes in Alaska, but be more disciplined with that when you travel outside this coming year. We don't know if Zika will be widely transmitted in the South or not, but it's certainly, it's going to be a very interesting summer, particularly along the Gulf Coast states.
Absolutely. I want to give a shout out, and I want to show your website. You've got a wonderful website.
Oh, thank you.
And in particular, I want to point out that individuals can subscribe to the public health announcement. So I would encourage our audience to do that. Also, I want to point out the advanced healthcare directive that is also on your website, and it's very simple. The number of individuals who do not have an advanced healthcare directive is surprising, and I actually just printed it out, and I have a graphic here of what it looks like. It's very simple. And why should people have a healthcare directive?
Well, it provides an opportunity for each Alaskan to designate someone that they would like to have who can make decisions for them regarding their medical care in the event that they are unable to make those decisions for themselves, or if they just want to delegate those decisions to someone else. It also provides the opportunity to specify how aggressive you would want treatment to be. So it's a document that needs to be updated.
Right.
Because as you get older, you may change your mind in terms of how much you would really want to have done.
And I have
let me also add, it's an
Sure.
important way to communicate with your provider. It's an important way to talk with family members. The Surgeon General, I thought, had an interesting idea to designate Thanksgiving as the time to have these conversations. Maybe after dinner, but it's
coffee.
It's an important conversation to have with your family.
Absolutely.
And I can say from personal experience, I'm very glad I had those conversations with my father before he suffered a catastrophic fall, and we had to make some very hard decisions about his medical care when he was in his 90s.
Yes, I'm glad you did. And since accidental falls, I have to mention, are the #1 cause of injury to Alaskans age 65 and older, you also have wonderful information on how to prevent falls on your website. And I do want to thank our special guest, Dr. Jay Butler, Chief Medical Officer with the State of Alaska Division of Health and Social Services and Director of the Division of Public Health. AARP is a nonprofit, nonpartisan member organization with more than 87,000 members in Alaska. AARP is dedicated to enhancing the quality of life for all as we age. We lead positive social change and deliver value to our members through information, advocacy, and service. Thank you for watching AARP Alaska.
Funding for this program made possible by the Investor Protection Trust, the State of Alaska Division of Banking and Securities, and AARP Alaska.